today we're talking about congestive heart failure. And we have a variety of specialty programs that I've written and that we're initiating so we can further distinguish ourselves from everybody else. A Nurse in a Family already is very different from all the other home care companies in existence, and this is making us even more different and more better. So we have 6 programs that I've written curricula for. Fresh Air program is for people that have congestive heart failure, and so today we have in front of you learning objectives. Each of the slides for the presentation is there, so you can take notes, and then there's a test. If you pass the test with 80% or more, then you can be certified to be part of the Fresh Air program. So when we have somebody enrolled in that program, you're ready to go and help them. Next month is diabetes. It's our Sweetheart program. Same thing. We're going to have exactly the same format, and so you can be certified as a Sweetheart program delivery. Safe Home program is fall prevention. Freedom of Motion program is people with arthritis. Memory Plus program is people with dementia, and hospice support. And so my hospice is very close to my heart, and my philosophy as an emergency doctor is that when we are supporting someone in a hospice program, as an emergency doctor, we're providing aggressive comfort care. And so we'll talk about that when we explore this. All right? So, but today is congestive heart failure. So your learning objectives today are, first we're going to talk about the normal function of the heart so that you understand how a normal heart works. And then we're going to talk about what goes wrong in congestive heart failure. You have to know the difference between signs and symptoms and what the signs and symptoms of worsening congestive heart failure are. Because one of the great advantages to working for this company is you have access to a physician 24/7. So if you have questions about somebody's worsening condition, call me up, we'll talk about it and see what we need to do. You're going to know how to monitor somebody, you're going to have some familiarity with the common medications used to treat congestive heart failure. And then we're going to talk about lifestyle issues, things that you can initiate with our clients or with yourself if anybody here has any heart problems. Okay, the normal heart. So this is a cutaway of the normal heart. And the heart's main function is to pump blood. That's on the test. The heart's main function is to pump blood. And there's the right side of the heart and the left side of the heart. And there's 2 circulations that the heart pumps blood through. The right side of the heart is weaker. You can't really see that so well in this illustration, but the wall is thinner and it's weaker because it doesn't have to push blood through as many blood vessels as the left side of the heart does. So blood comes back into the right side of the heart after the oxygen has been stripped off the hemoglobin, right? So that's why it looks kind of blue. Most illustrations you'll see the right side circulation looking blue. It comes in and it pumps through the lungs where oxygen fills the blood. Then it comes into the left side and it pumps and it goes to the rest of the body. So 2 circulations. That's on the test. So this illustrates the 2 circulations. This is the vascular architecture of the lungs, and you see there's a lot of blood vessels in there and it's very complex. And this is the vascular architecture of the main arteries in the body. There are over 100,000 miles of blood vessels in the body. If I took your blood vessels out of your body and I laid them down one by one, it'd be 100,000 miles of blood vessels. In babies, there's about 60,000 miles of blood vessels. And the purpose of the lung, we're going to talk about lung function now, is oxygenation and ventilation, and we'll talk about each one of those and what that means. If you have questions while we're going on, just stop me and just ask questions about it. So, in congestive heart failure, for some reason, the heart's not pumping as good as it should. Remember, the main function of the heart is to pump blood. Something has interrupted that. We'll talk about some of those things. And what that causes, if your heart, if it pumps blood out of the chambers, and then it relaxes and blood goes back into the chambers. If it hasn't pumped a lot of blood out of the chamber when it relaxes, more blood can't get in there. What happens then is things kind of back up behind there, which causes fluid buildup. If it's fluid buildup in the circulation of the lungs, you get fluid in your lungs. If it's fluid buildup in the rest of the body, you get fluid buildup in the rest of the body. That's called edema. So, things that can compromise heart function are heart attacks. High blood pressure, if you have hardening of the arteries in your heart, arteriosclerosis, that can cause it, or a valve. Say you have a faulty valve. So you think about, the left side of the heart is pumping blood out into the aorta for the rest of the body. The aortic valve, if it gets compromised, it won't open quite as much as it should, then the heart's pumping against that closed valve. And so that's kind of like a weightlifter that goes into the weight room and starts pumping weights. And if you do that, you get big muscles. That's not good in the heart. When you get those big muscles, then the chamber gets smaller and it can't fill with blood, and what happens is your pump function is compromised, and you can get congestive heart failure from that. Okay, so this is an x-ray of the normal lung. And so the way x-rays work, say I put an x-ray plate behind her, and I put something that emits x-rays in front of her, and x-rays go through her body and develop the x-ray plate behind. It's like film, okay? And so things that don't stop x-rays from going through the body, like things that are filled with air, cause the x-rays, let the x-rays go straight through to the photographic plate on the back. Things that absorb x-rays, like blood or water, absorb x-rays, and it doesn't develop the x-ray plate behind you. For example, this thing is full of water, blood. It's a heart. And so it's absorbing x-rays. So it's white. This thing is the lung. It's full of air. It doesn't absorb x-rays. So x-rays go straight through it and develop the plate. So things that are white are fluid, consistency of fluid. Things that are black, consistency of air. And so this is a normal lung. Diaphragm, nice heart border you can see here. You can see the trachea coming down here. It's an air, that's where you breathe into your lungs. And you can see one part of the trachea going off to the right side, one part of the trachea going off to the left side, shoulder, humerus, clavicle. There's a letter L to let you know that's the left side. Now this is congestive heart failure. So you can see what should be air density is water density. It's full of fluid. Lung function is severely compromised in this person. This person is near death's door.
Are they susceptible to pneumonia and all that?
Yeah, exactly. But their main problem here is fluid in little air sacs where gas exchange takes place. And so it's so much fluid, you can even see where the heart border is. I can kind of see it there because I've looked at thousands and thousands of x-rays, but yeah, it's really pretty hard to see. So in a normal lung, this is kind of a cutaway. We saw this on the x-ray. Here's the trachea, right main stem bronchus, left main stem bronchus, lung, different lobes of the lung. And now we can cut this away and look at kind of the microscopic architecture. Right there is the business end of the lung, the alveoli. And alveoli is where gas exchange takes place. The lung has two main functions: to bring oxygen from the outside world into your bloodstream, and through the mechanism of the body working, you create carbon dioxide. And so carbon dioxide in your bloodstream allow that to go out of the body into the outside world. You're breathing out carbon dioxide, you're breathing in oxygen. So breathing in oxygen, that's called oxygenation. Breathing out carbon dioxide, that's called ventilation. Oxygenation, ventilation, the main function of the lung. This is congestive heart failure. Look at that. Do you think that's going to be efficient at oxygenation or ventilation? No. Okay. So the main lesion in the body when you have congestive heart failure is decreased oxygen level in the bloodstream, increased carbon dioxide level in the bloodstream. That results in what you're going to see in terms of signs and symptoms, which we'll talk about next. All right. This is on a test. You have to know the difference between signs and symptoms. Signs are something you observe. Symptoms is something that the patient tells you they're experiencing, right? So these are signs right now because they're not talking to you. Okay, what's going on with this guy?
The guy?
Huh?
The guy?
Yeah, what's going on with this guy?
Having chest pains.
What's that?
Heart attack.
You talk.
His heart.
Heart. You talk.
Chest pain.
Maybe he's expressing love for his girlfriend. You don't know.
Sing
So
song.
that's why we're going to talk about documentation at the end of this. That's why you can't say this patient's having chest pain in your documentation. You can say, I witnessed a patient placing his hands to his chest and clutching his chest. That's an accurate observation. That is what goes in the medical record, not patient having chest pain. What's going on with her?
She's holding her temples.
So he's holding her temples. Good, Maya. Maybe her 3-year-old has colored on the walls one too many times.
Oh, yeah.
Okay? So, I mean, we don't know. She's holding her temples. Maybe she's got a headache. Maybe she's experiencing grief. Maybe she's pissed at her 3-year-old. We don't know. All right? So this is a sign. So Maya is exactly correct. A patient or client holding fingers to temple and grimacing. That's an accurate observation. Symptoms are something that the patient expresses to you. I'm having chest pain. I can't breathe. I have a headache. I feel nervous. Those are symptoms. And you write them as patient states, quote, I'm having chest pain, end quote, period, right? Not your, whatever you want to make up about what they said. It's exactly what they said. The words coming out of their mouth. So that an independent third party can look at that documentation and go, oh, this is what this person observed. You're a videotape when you're in the client's home. You're videotaping this for the next person that's reading the chart. Okay, so we talked about in congestive heart failure, there's two circulations, that's on the test. Fluid can build up in the lungs when the lung circulation is compromised, all right? And so these are the signs of somebody that's having less and less oxygen in their bloodstream because oxygenation has been compromised, like we talked about. So first thing, they're going to develop an increased respiratory rate. Because if you can move air in and out quicker, you can become more efficient at oxygenation. They might see accessory muscles of respiration being used. That's where, you know, their neck is being used to open their lungs like that. And that's also called, you know, you can observe that as increased worker breathing. So that's something you can observe and write down. Tripoding is the body position where you're most efficient at getting air into your lungs. You're sitting forward like this, like a tripod. If I'm in the ER and I walk by a room, and it's not my patient, and I see somebody tripoding with an increased respiratory rate and using accessory muscles of respiration, that's an emergency. I stop what I'm doing and I go pay attention to that person. If you have decreased oxygen level in your bloodstream, then your mental status is decreased as well. So you might become confused or sleepy or drowsy or not quite as alert as you would be. Coughing, you get fluid in your lungs, you start to cough. And if you're listening with a stethoscope, you can hear wheezing, right? Actual wheezing, which is whistling when you listen to the lungs. And cyanosis, finally, cyanosis is when things have really gone wrong for a long time and your lips turn blue and your fingernails turn blue. That's because you don't have any oxygen in your bloodstream anymore, or very little of it. Right? So these are signs of decreased oxygenation. Symptoms that someone may express to you if they have less oxygen in their bloodstream than they should are, I feel short of breath. I have chest pain. I'm feeling confused. I'm not thinking right. Or I'm nervous. Those are symptoms they express to you. So if I took you right now and put you on top of Mount Wheeler at 13,000 feet or 14,000 feet, whatever it is, you might experience some of these symptoms: shortness of breath, confusion, anxiety, chest pain. So that's because there's less overall oxygen up there. Your oxygen level will have fallen. Any questions about the signs and symptoms of decreased oxygenation? No. All right. Remember, it's oxygenation and ventilation. If you have increased CO2 level building up in your bloodstream because you have fluid in your alveoli and you're not exhaling CO2 like you should, these are the signs and symptoms you'll experience. Increased CO2, you have decreased mental status, you get sleepy, and you get increased respiratory rate. These are signs that you can see. Symptoms are sleepiness and confusion. Pretty much the same as decreased oxygenation. So luckily it's not too much to remember there. All right. So we talked about the lung circulation. Remember, fluid builds up in the lung, fluid builds up in the alveoli, decrease gas exchange. What happens if it's the left side or the right side of the heart that's not functioning and the fluid's backed up in the body? Well, you can have peripheral edema or anasarca. This is a picture of somebody's leg that has congestive heart failure. They have peripheral edema. It's swollen. What happened here, Maya?
Someone pushed on it, is what it looks
Put
like.
your finger in it. And they took their finger away, and it stayed like that. That's called pitting edema. So this is swollen. This can get so swollen that it's leaking fluid and weeping fluid, and you know the sheets are wet, the pants are wet. That's called weeping peripheral edema. I've seen it plenty of times. The skin kind of gets crusty and maybe a little red. Sometimes it's confusing to tell in the ER, does this person have an infection in their leg?
Staff.
Or is it just edema? You know, so because that edema will decrease, you know, obviously your blood isn't returning like it should, so you're not clearing bacteria like you might, so you can get increased risk of infection here. So one of the things you're going to look for in physical examination is peripheral edema and pitting edema, and if it's edema over your entire body, that's called anasarca.
And what are the best things to do when treating peripheral edema?
We'll talk about that. Good. You lead me right into it. So this is the scale that we go by in terms of grading how much edema there is. Because you can have a little bit of pitting edema or a lot of pitting edema. And if you follow, this is kind of getting into the meat of this now, if you're staffing somebody in our fresh air program, and on Monday they have 1+ pitting edema, but on Thursday they have 4+ pitting edema, they're getting worse. You call me, okay? And so this is how it works. 2 millimeters into the skin is 1+, 4 millimeters is 2+, so forth and so on. And you have that in your slides there. And over time, when you've done this enough, you just kind of get a feel for it. You don't actually measure it, you just kind of get a feel for it. Oh, that's 4+ pitting edema. Okay. The other thing that you're going to be monitoring is vital signs. So you need to know what normal vital signs are. So a normal heart rate is between 55 and 100. If you have slower than that, you have bradycardia. Faster than that, you have tachycardia. Normal respiratory rate is between 12 and 20. So Maya, if you call me up at 3 in the morning and say, hey, I'm with Mr. Jones, he's in our fresh air program, and he looks like he's having some trouble. I think he's getting worse. I'm going to ask you, what are his vital signs?
Right.
I'm going to ask you, what's his respiratory rate? And so you need to know, I mean, and you need to have the judgment of when to call. It's like if his respiratory rate was 18 2 days ago and now it's 30, that's bad, right? Normal blood pressures between 90/60 and 140/90. And normal oxygen saturation, it varies with the altitude you're at. But usually around here, it's around 95 is the lower limits of normal. I've seen people in low 90s, it's normal for them. And oxygen saturation is very easy to check. We have a pulse oximeter probe that just goes on your finger, turn it on, the light comes on and tells you a number. It's very simple. It tells you the percent of oxygen in the arteries. Okay, so monitoring vital signs. So you're going to be looking at work of breathing, accessory muscles of respiration, tripoding, and just, the judgment, how do they look? It's funny, in medical school, you kind of lose some of the judgment. Like, if you guys have never had any medical training, and you see somebody that's sick, you just recognize, hey, that person's sick. You just know it. And when you go to medical school, you start, like learning criteria for things and numbers for things, and you start measuring everything, and you forget how to look at someone being sick. And then over time, you develop that sense again. So just use your gut too on this. Does this person look sick? Do they look sicker than they looked yesterday? Should I be worried about this? And then go measure things, and then give me a call. So physical examination, you're looking for the degree of peripheral edema. Are they wheezing? What's their mental status like? Are they coughing? And what is their weight doing? If you remember that big fat leg we saw, if someone's starting to gain more fluid in their body with peripheral edema, their weight's starting to go up. So one of the things we're going to do with our fresh air program is weigh people every day. Take their vital signs and weigh them. Take their vital signs and weigh them. Take their vital signs and weigh them, and make observations about their work of breathing. And say if their weight's going up, their oxygen saturation's going down, heart rate's going up, bad trends.
So are we gonna have to take our own equipment to do vitals?
We'll probably have equipment in there for you. Those of you that have your own equipment, obviously always have it with you in the car. Have your gait belt, have your blood pressure cuff, have your stethoscope, have your pulse oximeter with you. Now you're a fully functioning unit wherever you are. Okay. Talk about this. So dyspnea is shortness of breath, and one of the earliest signs of worsening congestive heart failure is getting short of breath when you're doing something. Dyspnea on exertion. So, if someone could walk up the stairs yesterday without getting short of breath, and they're in the fresh air program, and today they're getting short of breath, watch that. The other thing that's not on this list is something called orthopnea. Do you know what that is? Anybody know what orthopnea is? That has to do with how many pillows you need to sleep on at night.
Down.
Because if you have congestive heart failure, you have fluid in your lungs, it's more efficient to be upright in breathing. If you lay down, and the fluid gets worse in your lungs and it's harder to breathe. So people with congestive heart failure will sometimes put a pillow behind them, and then 2 pillows, and then 3 pillows, and we record that as, in the ER as 3-pillow orthopnea. Patient reports 3-pillow orthopnea. That's a sign of worsening congestive heart failure. Okay, so these are trends. This is a moving target. This is a movie, not a snapshot. Are they showing increased signs of work of breathing, increased heart rate, decreased oxygen saturation? Are they needing more oxygen? A lot of these folks are on supplemental O2. If they're turning up their oxygen, that's because they're experiencing shortness of breath and they're trying to treat it themselves. Is your weight increasing pitting edema? That's it. All right. We're going to talk a little bit about medications, just so you kind of are familiar with what's in the person's med box at home. These are the most common medications used to treat congestive heart failure. ACE inhibitors, beta blockers, vasodilators, and diuretics. I'll talk about each one of those just a little bit in just a tiny bit of detail. And if you have more questions about that later, just ask me about them because these are interesting. So ACE inhibitors, luckily, the drug companies helped us out by having them all end in pril, enalapril, lisinopril, but then there are common names for them too, and for them as well, Lotensin, Vasotex. So if you see those in someone's med box or in their med list, if they're in the Fresh Air program, or any of our clients, you know this is an ACE inhibitor. And ACE inhibitors all work the same way. They result in lower blood pressure. And they do it by, there's a whole cascade, and the next slide is this big cascade, but this is the punchline. You have floating around in your bloodstream hormones that are ready to be activated. An angiotensin converting enzyme changes angiotensin 1 to angiotensin 2. Angiotensin 1 doesn't do much. Angiotensin 2 is very active, does lots of things. It causes your blood vessels, there's muscles inside the blood vessels, we'll look at that in a second. It causes the arteries to squeeze into smaller tubes, which increases your blood pressure. And it causes your kidneys to pull water out of your urine into your bloodstream so that you have more blood volume, increases your blood pressure. So in response to hypotension, your body does this, all right? So if you're trying to treat high blood pressure, and you can stop this from happening, you can stop that from happening, which will cancel the entire cascade. So this is busy, I understand, but this kind of gives you a big picture, and you have it in your slide set there, kind of a big picture of what angiotensin 2 does. Increases the sympathetic activity inside arteries, which causes the arteries to squeeze into tighter and tighter tubes, which increases blood pressure, pulls water out of the kidneys, like I said, out of the urine, and increases blood volume. It does a lot of other stuff too, which is beyond the scope of this talk. So, angiotensin converting enzyme inhibitor toxicity, they're really pretty safe drugs. You can take a handful of them and probably nothing bad will happen to you. But any antihypertensive can cause low blood pressure. And then this thing right here is one of the most common side effects of an ACE inhibitor, and that's called angioedema. Swollen lips, swollen mouth, swollen tongue, and it goes away when you stop the ACE inhibitor. So if you have a client on an ACE inhibitor, remember it ends in the letters pril, and they develop a fat swollen lip, remember this, right? Now all they have to do is stop the ACE inhibitor, a day or two it goes away. The other things this causes is kind of spasming of the airways in your lungs, called bronchospasm, and causes kind of a chronic cough. When I first got diagnosed with high blood pressure, I got placed on lisinopril, and after a couple years I developed a cough. Taken off the lisinopril, coughing away. So those are the common
Some
ones.
women would pay for that.
What's that?
I said some women would pay for that.
Oh yeah, some women do pay for that. Beta blockers. Once again, the drug companies helped us out. They end in LOL. Okay, atenolol, metoprolol, common names, tenormin, Lopressor. You'll see these in the med kits of our clients. And what this does is it stops beta receptors live on cell membranes, and they get stimulated by epinephrine and norepinephrine. So beta blockers block those receptors, and so it stops norepinephrine and epinephrine from doing their job. And so beta 1 receptors are in the heart, and so that causes decreased heart rate and contractility. Beta 2 receptors are in blood vessels, relaxes smooth muscles. Beta 3 receptors are on fat cells. I don't know what they do. And once again, I just want to, you'll see this a couple times. This is a cutaway of an artery. So it has multiple layers. The inside is called the lumen, that's where the red blood cells are. Right here is something called the media, that's a muscular layer. And so if you have increased nervous system stimulation to the media, what it causes is the blood vessel to squeeze shut like that, which pushes the blood pressure up. Beta blocker toxicity, now we're getting into dangerous drugs. These can kill you. Low blood pressure, causing too much, the heart to slow down way too much. It can cause arrhythmias and seizures even. And it also, the beta receptors control glucose regulation as well. And so if you have beta blocker toxicity, your blood glucose can drop to 0 as well. So that's just one other side effect of beta blockers.
So hypotension comes from beta blockers?
Hypotension.
Hypotension.
So hypotension is what? High or low blood pressure?
High.
Low.
Low.
Hypo. Hyper is high. Hypo is low. Okay, diuretics, very common. You'll see Lasix out there, hydrochlorothiazide. These are very common medications, and they all kind of work in the same way. They work at the kidneys. And so this is on the test. Where sodium goes, that's where water goes. And what these things do is they pull sodium, they keep sodium from being pulled out of the kidney, out of the urine, into the bloodstream. Now, if your body wants to reabsorb water from your urine, the way it does it is it pulls sodium out of the urine into the bloodstream. And when it does that, the water that's in the urine follows it. So for example, Adrian, if you're hiking in the mountains on a hot day, you don't bring any water with you, and you go pee on a bush, is your urine dark or light?
Dark.
Dark, because you're dehydrated, because your body has pulled sodium out of your urine, which pulled water out of your urine, so that you have blood volume, right? Same thing, you drink a lot, and it gets lighter, right? And so what diuretics do is keep your body from reabsorbing sodium. And it does it, so just to remind you about, the kidneys kind of live here in the body. There's a tube that drains urine into the bladder, then you pee it into the outside world. This is kind of a cutaway of a kidney that's showing really complex architecture. And here is what it looks like at the microscopic level under a microscope. So this is the business end right here. So blood comes in, blood comes out, toxins are screened out, water goes out here, urine's created right there, and right here is where the body, when it wants to, posts sodium out of the urine, which pulls water out of the urine. This is on the test. That's how all diuretics work. It keeps that from happening. It keeps the sodium in the urine. So in fact, what that does then will pull water out of the bloodstream, which lowers your blood volume, which lowers your blood pressure. And that creates more dilute urine, so your urine is clearer. So if someone's on a diuretic, Maya, should they take it in the morning or at night, and why?
I would say in the morning.
Why?
I don't know, honestly.
Anybody know why?
They're gonna be peeing on that.
They're gonna be peeing all night. Exactly right. So you take it in the morning, not at night. Okay, diuretic toxicity. You can have low blood pressure again, very low sodium, hyponatremia, very low calcium, hypokalemia. It can interrupt, when you have low sodium, low potassium, that can interrupt how the heart beats. It can cause arrhythmias, it can cause death. So this is once again a dangerous drug. Finally, nitrates, which is kind of my first line drug in the ER for congestive heart failure. And nitrates, here's some examples of them: Imdur, nitrobrid, nitroglycerin. So you'll see people sometimes have patches of these, or they'll take them under their tongue. And this is exactly the same chemical that blows things up. Nitroglycerin, the chemical that blows things up, same thing.
So these are used to treat edema.
This is used to treat congestive heart failure by dilating blood vessels. Okay, and the way the nitrates work is it changes nitroglycerin gets changed into nitric oxide, which is a very potent vasodilator. Relaxes, once again, this part right here, this muscular layer inside the arteries. It relaxes that, which causes blood vessels to dilate. And just think about what that does to pressure. So if I have a blood vessel that has this much volume and I squeeze it, is blood pressure going to go up or down? All right. If I have a blood vessel that has this much volume and I stretch it out, blood pressure go up or down?
Down.
Down. That's what this does. That's it. Nitrates. And the side effect of nitrates is hypotension, low blood pressure. Once again, low blood pressure is so low it can kill you. So this is a dangerous drug as well. Okay.
What's dangerous or more dangerous, hypotension or hypertension?
It depends. They can both kill you. Hypotension will kill you quicker. Yeah. Hypertension usually kills you over years. All right. Now we're talking about lifestyle stuff, right? Things that you can bring home to your client. All right, dietary considerations. What is the main thing to remember with regard to diet with somebody that has congestive heart failure?
Low sodium.
So what does that mean in terms of diet?
Salt.
Salt, great. What's the second thing you have to think about?
That's pretty much it.
Water.
Salt, salt. Okay, salt. That, I mean, there's other things that make a little bit of difference. This is the big thing. So when you're cooking meals for our clients that have congestive heart failure, don't add salt, okay?
Or sea salt.
What?
Sea salt. Sea salt?
No, it's still the same thing. Sodium chloride, sodium chloride, sodium chloride. So no matter what form it comes in, it's sodium chloride, don't use it. Use herbs and stuff to kind of spice up the food a little bit. You know, we're so used to salt in this culture that it's hard to get away from it, but you can. And sodium comes in a lot of forms. When you're using prepared food, look at the can, look at the label, look at the sodium content, because they'll hide it in there for you, okay? So salt, salt, salt. Main thing to consider. Linda,
What is the milligrams that is acceptable?
I'm sorry, I can't understand you.
What's the milligrams that are acceptable like for a normal diet?
Good question, I don't know. Let's look that up.
Because it'll have on there, you know, the salt content, but you don't know if that's good or bad if you don't know.
Salt content should be
Usually
zero.
percentage it next to it.
Right.
Yeah,
Well,
Daily value.
still, it's the same thing, if you don't know what percent you should have.
that's a really good question. Let's look that up.
Where?
I don't know, I'll look it up for you and I'll tell you. How about that? In fact, Chantal, can you go and just look up, good, you're looking it up now, aren't you?
What is it?
What's the normal acceptable sodium content for a diet for a healthy adult? And when you know, raise your hand and I'll recognize you. Okay, so you guys will have tools when you're at our client's home to help them with their diets. One of the things that we're going to start doing is our friend who's a chef that during orientation is going to give us a food module. A couple of hours on kitchen hygiene and how to prepare food, and we'll roll up our sleeves and do some stuff, make some things, right? And so you guys that have already been through orientation are welcome to come back to experience that as well. In fact, I insist on it. Come back and experience that as well. So we're all going to be trained up by a chef. Yes, Chantal.
It says between 135 and 145 milliliter equivalents to whatever it is that you're doing.
Okay.
Milliliters or.
Milligrams or milliliters?
It says millimeter equivalents.
Millimeter?
Millimeter
Okay,
equivalents.
I don't understand. That doesn't make any sense. It should be milligrams.
Milli equivalents per whatever, per liter or per whatever.
Okay, can you see if you can find a source that gives you milligrams? Because I would understand that. Okay, so this guy, Dr. Stephen Gundry, is kind of a pioneer on healthy diets. He's a cardiothoracic surgeon, and he's pioneered something called the Paleolithic diet. And so this website, which we're going to go to right now, is available to you on your smartphone. So you can go to this website and look at a variety of really healthy meals. Let's see if this works. And I corresponded with Dr. Gundry, and he said, go ahead and use my stuff, just give me credit for it. And so, Dr. Gundry, thank you for that. So you can browse by category. Let's go to dinner. Let's go to American, cooking method by baking, and go. And you have these recipes. You can click on these recipes. These are great. Now, these are not specific for congestive heart failure. So when you see something like salt to taste, stop that.
Right.
Don't salt to taste, right? Everything else is fine. When you're adding extra salt, stop right there. Okay, so anyhow, that's very easy. You have that website in your handout, so feel free to program it in your bookmarks on your telephone, and you can look that up right away. Yes.
CDC says 1,500 milligrams, no more than that a day.
1,500 milligrams a day, Linda. So less than that in these guys.
Right.
Okay. All right.
How would you translate that, like in spoons?
I don't know. Okay. So, treating congestive heart failure. You have somebody with congestive heart failure. What do? You make sure you're on the right medications. Let's take a look at lifestyle, diet, exercise. I have a friend I went to residency with who did cruise medicine. And so you go on a cruise ship, he'd be the doc, right? He gets to go for free, but then he has to be available to treat people. And he said all the time, the main thing they see is these little old people with congestive heart failure that end up with florid pulmonary edema because, damn it, they're on vacation and they're gonna have some salt. And so they forget, they don't take their medicines like they should, they salt their food, they eat the restaurant food, and they come in with congestive heart failure. So diet, exercise. Okay, if someone has fluid buildup in their lungs, pulmonary edema, then they may need to increase their oxygen supply. And if you've got, getting back to your question earlier, if you've got swollen legs, peripheral edema, elevate the legs. Right?
So,
Use gravity as your friend, because if you let gravity pull your blood down into your legs, then you won't get rid of that edema. Put your legs above your heart, gravity will pull it out. Yes.
so peripheral edema is always due to congestive heart failure.
No, a lot of things cause peripheral edema. Kidney failure causes it, other things cause it, but congestive heart failure is a very common cause of peripheral edema. And compression stocking, TED hose, put those things on. They'll just squeeze the fluid right out of the legs. Okay? All right. So we're going to talk about documentation now. Remember the difference between signs and symptoms. If someone has a symptom, you're recording it with quotation marks around it. We're going to practice this as well. So you're going to turn over your handout. On the blank part on the back, we're going to talk about SOAP notes. SOAP notes is how I want you to document when you're documenting for our clients in the Fresh Air program. Let's say SOAP stands for Subjective, Objective, Assessment, and Plan. So subjective is, what does the client say? Like, quote, I can't breathe, end quote. Client states, colon, quote, I can't breathe, end quote, period. That's S, you're done. Objective, client is holding their chest. I observe client to be clutching their chest. Vital signs go here as well. Heart rate, blood pressure, whatever vital signs you've recorded. Assessment, that's your concept of what's going on. I believe client is experiencing shortness of breath from worsening congestive heart failure. Plan, call 911, call Dr. Nelson, elevate the legs, whatever it happens to be. Each time it's different, okay? So we're gonna practice that now. I'm gonna be your patient. I'm gonna have some, I'm gonna say some things, you're gonna write some things down, and you're gonna come up with a SOAP note for me, okay? All right, here we go. Oh, Arena, I just came in, it was snowy outside, I fell, I landed on my shoulder, it hurts a lot right now, my hand is numb. I wonder if I broke it. Go, write your note. That's all you get. Maya, read your note.
I fell, quote, I fell and I can't feel my hand. I wonder if I broke my shoulder. Objective, I would put, I did not see them fall, because they didn't.
Okay. Okay, who else has another objective, different objective? Adrian, objective.
He was holding.
Holding,
Okay.
patient is grimacing, holding his shoulder, appears to be in pain.
Okay.
Assessment, Maya.
I would check out the client. I would assess them.
No, assessment, you've already done it.
Oh, okay.
You've already done your physical examination, and here's what do you think is going on?
Oh.
Adrian, what's going on? What do you think is going on?
He injured himself.
Yeah, he has shoulder pain, so
Plan.
plan, position of comfort, and call you.
Good, not bad. Okay, let's do it again, next time. Ready? Here we go. Adrian, I don't know what's going on. I just can't catch my breath. My chest hurts. Go. Linda.
The patient is reporting that he can't breathe and his chest hurts.
Good, that's S.
And then also that I've observed that he's breathing hard, holding his chest, and I thought of something else too, but I forgot.
A.
And then my assessment is that he might be having a heart attack or pulmonary problems or something.
P.
The plan is to find out by calling a doctor or 911 if necessary.
All right, this is where your plan is. You're not mincing words anymore. You have a plan and you're gonna execute it. What's your plan right now?
911.
Right, your plan.
Sit him down, try to calm him down, call 911.
Your plan.
Down, calm down, call 911 and call you.
911. Good, 911. That's it. Okay, this is how I would say that. Okay, S. Patient states, I can't breathe, my chest hurts. Quote, end quote, period. O. I observe client holding his chest and grimacing. A. Client appears to be.
Oh, I remember.
Okay.
Sorry. He appeared confused because he couldn't understand what was going on.
Okay. So anyhow, O. Client is clutching chest, using accessory muscles of respiration, assuming the tripod position. A. Patient appears to be short of breath, experiencing chest pain, concerned about a cardiac or pulmonary etiology, just like you. P. Call 911. Okay, last one. Let me see, what is it? Oh, Arania. I had this horrible cough. It seems like I really can't catch my breath. I felt like a fever, coughing up this green stuff. I wonder what's wrong. Go. Okay, Ryan.
For us, it's horrible cough, I have fever.
So you start by saying subject.
Subjective. I have this horrible cough, I have a fever, I'm coughing up screen stuff, I don't know what's wrong.
Okay, so patient states.
Patient says.
Okay, so that's how that goes every time. Patient states, quote, words, end quote, period. Okay, next one.
Okay, and then the objective is patient appears to have a cough, coughing up green phlegm.
Did you see green phlegm?
Already said.
Did you see it?
Say again?
Did you see it?
Did I see it? Oh, well.
It's subjective.
Over here.
It's only what you saw.
Oh, okay, yeah, okay, so just patient appears to have bad cough and
Patient is coughing.
it's got
That's all you got. Patient's coughing.
Okay.
All right, assessment.
Assessment, patient appears to have some sort of lung infection, possibly bronchitis, and then my plan is to call you and then bring the patient to the doctor.
Good. Great. Anybody want to add anything to that? Okay, soap notes take a little bit of practice. You've just gotten your toes dipped in the water of soap notes. I want you to practice them a little bit. No one is interested in your opinion until you get to assessment. Your opinion that I'm coughing up green stuff means nothing unless you've seen it, okay? So that's that. You have a test now. Any questions before the test?